Chapter 13, the adrenal glands. This chapter provides an overview of relevant anatomy, embryology, scanning techniques, functional and morphologic adrenal pathology, and the sonographic appearance of the normal gland, as well as adrenal pathology. As a sonographer, it is important to develop critical thinking and problem-solving skills for sorting out the origin and extent of the abdominal masses, including those of suprarenal and retroperitoneal origin. Related techniques are discussed. In addition, EUS, IOUS, CT, MRI, and associated NICMED imaging procedures are presented as related to adrenal imaging. Due to technical improvements in all the diagnostic imaging modalities and the increased use of these modalities, more clinically silent or unexpected masses are being detected. The general term for an unexpected mass detected during an imaging procedure being performed for unrelated disease is incidentaloma. This term may be applied to any unexpected mass occurring anywhere in the body. Adrenal incidentaloma, or AI, has become a common term in the medical literature and represents a diagnostic challenge that includes discovery of masses which range from benign non-functional lesions to malignant tumors such as pheochromocytomas, adrenocortical carcinomas, or metastases from other primary cancers. Sonographers have a role both in the initial detection of AIs and in gathering diagnostic information regarding newly discovered AIs. Anatomy. Embryology. The adrenal gland consists of two distinct pairs, the cortex and the medulla. Each develops from a different embryonic tissues, forms different anatomic and functional structures, and combines within a common capsule. The result is two endocrine glands in one organ. Most glands of the body develop from epithelial tissue. In contrast, the adrenal cortex is derived from the mesoderm of the same region that gives rise to gonadal tissue. The central tissue, or adrenal medulla, is functionally part of the sympathetic nervous system developed from the neural crest cells that also give rise to the postganglionic sympathetic neurons. As a result, some adrenal medullary pathology may appear ectopically along the paths of these sympathetic neurons, usually near the celiac axis, whereas ectopic adrenocortical tissue may be located inferiorly along the path of gonadal tissue migration. In addition, extraadrenal chromaffin cells also normally deposit near the aortic bifurcation to form the organ of Zuckerkandl. Cortex. During gestational weeks 5 and 6, the fetal cortex is first recognized bilaterally as a groove between the developing dorsal mesentery and gonad. During weeks 7 and 8, the cells arrange into cords with dilated blood spaces, forming a thin capsule of connective tissue that encloses the gland and develops an intimate relationship with the superior pole of the kidney. If the kidney does not develop normally, there will be a discoid distortion in the shape of the adrenal gland. Initially, the fetal adrenal gland is larger than the kidney and 10 to 20 times the relative size of the adult adrenal gland. During the remainder of fetal life, the cortical tissue is composed of two zones Cortical tissue is composed of two zones comprising 75% to 80% of the bulk of the gland. By week 8, the cortex produces precursors to androgen, estriol, and corticosteroids. After birth, the inner zone undergoes involution, whereas the thinner outer zone continues to develop into the adult adrenal cortex, which takes on a yellow color. By the age of 3 years, the cortex differentiates into 3 zones. 1. Zona glomerulosa. 2. Zona fasciculata. And 3. Zona reticularis. Each zone develops different cellular arrangements and becomes functionally specialized, producing mineral corticoids, glucocorticoids, and gonadocorticoids, respectively. Medulla. Specific ectodermal cells ascend from the neural crest, migrate from their origin, and differentiate into sympathetic neurons of the autonomic nervous system. Some of these primitive anatomic ganglia differentiate even further into endocrine cells, designated chromaffin cells, and migrate to form a mass on the medial surface of the fetal adrenal cortex. Soon, these chromaffins, or pheochrom cells, invade the developing cortex, establishing the primordium of the adrenal medulla. On cut section, the medulla has a red, brown, or gray color depending on the level of blood perfusion. As mentioned previously, the chromaffin cells also form the organ of Zuckerkund. Relational anatomy. Like the kidneys, the adrenal glands are retroperitoneal. They are generally anterior, medial, and superior to the kidneys. The cortex and medulla are encapsulated by a thick inner layer of fatty connective tissue. A thin fibrous outer capsule attaches to the gland by many fibrous bands, providing the adrenals with their own fascial supports so that they do not descend if the kidneys are displaced or absent. The glands are attached to the anteromedial aspect within renal fascia, also referred to as Gerata fascia, and abundant adipose tissue or perinephric fat surrounds each gland, separating it from the kidneys. Right adrenal. The right adrenal gland is located posterior and lateral to the IVC, medial to the right lobe of the liver, and lateral to the crew of the diaphragm. The right adrenal gland has been described as sitting like a triangular cap on the anterior, medial, and superior aspects of the superior pole of the right kidney. The anterior surface of the right adrenal gland is shaped like a pyramid. 2 areas make up the anterior surface. The medial area is narrow and lies posterior or lateral to the IVC, and the lateral, somewhat triangular portion is in contact with the liver. The superior end of the lateral area is devoid of the peritoneum as it comes in contact with the bare area of the liver, and the inferior portion is covered by reflected peritoneum from the inferior layer of the coronary ligament. A curved ridge separates the posterior dorsal surface into superior and inferior parts. The superior convex portion rests on the diaphragm, and the inferior concave portion is in contact with the superior anterior surface of the right kidney. Left adrenal. The left adrenal gland appears draped in an elongated crescent or semilunar shape on the medial aspect of the left kidney's superior pole. The left gland is larger than the right, and extension of the left renal hilus is a normal variant. The anterior portion can be separated into superior and inferior parts. The superior area is situated posterior to the peritoneal wall of the lesser sac and is covered by the peritoneum of the mental bursa, which separates the gland from the cardiac portion of the stomach. The inferior area is not covered by the peritoneum and lies posterior and lateral to the pancreas. The splenic artery and vein course between the pancreas and the left adrenal gland. The posterior surface is in close proximity to the splenic nerves. It is divided into a medial and a lateral area by a vertical ridge. The larger lateral area rests on the kidney, and the medial posterior area of the crew of the diaphragm. Systemic and lymphatic vessels. Similar to other endocrine glands, the adrenals are among the most vascular organs of the body. The vasculature of the adrenal gland is distinguished from other organs in that the arteries and veins do not actually course together. The abundant arterial supply may contain as many as 50 to 60 small terminal arterioles, whereas the venous blood is channeled almost completely through a single large venous trunk. Arteries. 3 arteries supply each gland. The superiorly located suprarenal branch of the inferior phrenic artery, the superior and medially located branch of the aorta, and the inferiorly located suprarenal branch of the renal artery. These arteries are distinctively classified into 3 types: short capsular arterioles, intermediate cortical arteries, or long branches that go through the cortex to the medulla, and the medullary sinusoids. Veins. In each adrenal gland, a central vein runs the length of the gland and exits at the hilum. The right suprarenal vein empties directly into the posterior aspect of the IVC as a short 4 to 5 millimeter vessel, which exits the gland on the mid-anteromedial surface. The left suprarenal vein drains directly inferior and medial into the left renal vein. Frequently, the left inferior phrenic vein and the left suprarenal vein join before emptying into the left renal vein. Lymphatics. Lymph channels drain from the adrenal cortex and medulla to the hilar area. Following the arterial pathways, larger lymphatic vessels drain into para-aortic and lumbar lymph nodes, which drain to the cisterna cala, thoracic duct, and eventually into the subclavian vein, whereas a few lymphatic vessels drain into the posterior mediastinal lymph nodes. Physiology. Just as their origin and structure are unique, the function and control of hormones differ for these 2 different glands in one organ. Adrenal pathology and some medications have the potential to disrupt the level of adrenal hormone secretion and associated regulatory mechanisms. Hormones produced by the adrenal cortex, such as cortisol, are essential to life and must be replaced if both adrenal glands are removed. Cortex. The cortex makes up 90% of the adrenal gland. By 3 years of age, the cortex develops into 3 epithelial layers, each one evolving functionally into very specialized zones, producing steroid hormones consistent with their mesodermal source. The zona glomerulosa, the outer layer directly beneath the connective tissue covering, makes up 15% of the cortex and produces aldosterone, a mineralocorticoid. The zona fasciculata, the middle layer, comprises 75% of the cortex, and the zona reticularis, the inner layer, accounts for the remaining 10% of the cortex. Cortisol, a glucocorticoid, and 2 gonadocorticoids, estrogen and androgen, are produced by the zona fasciculata and zona reticularis. Hormone secretion is often controlled by the negative feedback mechanisms. Low blood concentrations of a hormone trigger the hypothalamus to secrete the primary regulating factor, corticotropin releasing hormone, or CRH, which triggers the anterior lobe of the pituitary to release adrenocorticotropic hormone, or ACTH. As blood concentrations of ACTH increase, adrenal hormone activity increases, producing a higher concentration of hormones such as cortisol in the bloodstream. This increased concentration of the adrenal hormone inhibits CRH and ACTH and ultimately hormone synthesis. When the blood concentration of one or more of the adrenal hormones drops to low levels, the cycle is repeated. Adrenocortical hormone secretion, function, and regulation are summarized in Table 13.1. Medulla. Originating from ectodermal cells, the medulla secretes catecholamine hormones similar to the posterior pituitary and thyroid glands. The medulla's chromaffin or pheochrome cells, the hormone-producing portion, surround large blood-filled sinuses. Epinephrine or adrenaline, and noradrenaline, are the two principal hormones synthesized by the medulla. Epinephrine constitutes about 80% of the total secretion, and its action is more important than norepinephrine. Release of both hormones is usually stimulated through the sympathetic nervous system. Adrenal nerve stimulation results in prompt discharge of medullary hormones without materially influencing cortical secretion. Hormone secretion is controlled directly by the autonomic nervous system, and innervation by preganglionic fibers allows the gland to respond to neural stimulus. The anticipation or presence of stress or pain causes the hypothalamus to signal the sympathetic preganglionic nerves to stimulate the chromaffin cells to increase output of epinephrine or norepinephrine. Functionally, the medulla is a large sympathetic ganglion which triggers action via hormone release instead of through axons. The body responds by 1. Accelerating the heart rate and constricting the vessels, causing increased blood pressure. 2. Accelerating the rate of respiration and dilating the respiratory passage. 3. By decreasing the rate of digestion to make available more blood to the muscles, increasing the efficiency of muscle contraction. And 4. Increasing the blood sugar level to provide energy, thus stimulating cellular metabolism. This physiologic response to stress is better known as the fight or flight response. Hypoglycemia, hypotension, hypoxia, hypovolemia, and exposure to temperature extremes may also stimulate medullary secretion of epinephrine or norepinephrine. Like the glucocorticoids of the adrenal cortices, these hormones help the body resist stress. However, unlike the cortical hormones, the medullary hormones are not essential to life. Function test. There are many different kinds of laboratory tests to evaluate adrenocortical function. They can be divided into two types: tests that determine the absolute values in serum and urine versus tests that check the interdependency of the various hormones. Table 13.2 summarizes the significance of increased and decreased variance from normal laboratory values for various serum and urine tests. Of the limited tests available for testing medullary function, 24-hour urine samples are typically used for catecholamines. Metanephrines are measured in urine, whereas dopamines may be assessed via urine or blood samples. With hypertension, pheochromocytoma, or neuroblastoma, urine levels of catecholamine and vanillometalic acid, or VMA, or both may be elevated. Multiple tests are designed to determine the true functions and interdependency of the hypothalamus, pituitary, kidneys, and adrenals, including stimulation and suppression testing for ACTH, aldosterone, and cortisol. Sonographic scanning technique. Preparation. Usually patients receive no preparatory instructions for sonography of the adrenal glands, but when there is suspicion of a mass or metastasis or a need to image any retroperitoneal anatomy sonographically, it is recommended that the patient fast approximately 6 to 8 hours before the examination. Scanning protocol. Evaluation of adrenals may be approached with the patient in supine or decubitus positions. Common protocols typically begin with transverse scanning, followed by longitudinal and/or coronal assessment. Slight or small scanning maneuvers are used to obtain desired images. One of the imaging goals for the adrenal sonography is to document unilateral versus bilateral pathologic involvement. As with most sonographic examinations, width and anterior-posterior measurements in transverse sections and length measurements from the longitudinal coronal sections are required. Various breathing excursions and suspended inspiration may be used to optimize visualization of both adrenal glands. Select the highest frequency transducer that will provide adequate penetration given the adrenal depth range of 4 to 12 centimeters, depending on the patient's size. Selection of a transducer with a small footprint will also facilitate scanning through intercostal spaces. Magnifying the field size may improve visualization of small structures. Scanning the patient in a prone position is uncommon, although this method is useful to show the spatial relationship between a large adrenal mass and the adjacent kidney. Right adrenal. For imaging the right adrenal, the liver, and sometimes the right kidney are useful acoustic windows. Successful utilization of the liver as an acoustic window depends on hepatic size and attenuation characteristics. Starting with transverse scans using an intercostal approach, find the section of the IVC located medial and anterior to the upper pole of the kidney. Direct the plane toward the lateral and posterior aspects of this portion of the IVC while also keeping the ultrasound beam perpendicular to the spine. The adrenal gland should be seen in this location anterior to the crew of the diaphragm. The entire right adrenal gland is evaluated by scanning transversely from the renal hilus and proceeding superiorly. Longitudinal or coronal scanning of the right gland can be accomplished with several approaches. A higher success rate has been reported when utilizing the liver as an acoustic window and scanning the patient in a left lateral decubitus position. For an intercostal window, the transducer is aligned anterior toward the IVC and posterior toward the right kidney until the entire gland is visualized in the longitudinal or coronal plane. Left adrenal. The left adrenal gland is more difficult to locate and document. Conventionally, the left adrenal has been imaged with the patient in the right decubitus position using the spleen or left kidney as an acoustic window. Identifying the left adrenal and its alignment is first done in the transverse plane. The left adrenal should lie between the left kidney and the aorta, with the pancreatic tail and splenic vein marking the superior margin of the gland. Longitudinal or coronal scans may be easier to obtain with the patient in the right anterior oblique position using a left posterior oblique scanning plane. First, in the transverse plane, locate the aorta medial and anterior to the upper pole of the left kidney or the spleen until the axis of the left kidney and the position of the aorta are determined and the left adrenal gland is identified between these structures. With the patient in the same position, rotate the transducer into the longitudinal coronal plane. When imaging the left adrenal gland, the transducer may have to be oriented obliquely. In the mid-1980s, Krebs and colleagues introduced an alternative approach to improve localization and delineation of the left adrenal gland. The patient is placed in the 45-degree left posterior oblique position, termed the cavo-superior line position. The transducer is placed on the patient's right side, allowing the acoustic beam to pass through a double vascular acoustic window, the IVC, and the aorta. The protocol starts with transverse scans until the left adrenal gland is located. Longitudinal views follow. With this position, the success rate is 90% compared to 60% in the same patient population using the conventional approach. Pitfalls. The size, location, and pathology of the adrenals and of surrounding structures impose significant limitations on sonographic visualization. Cirrhosis with fatty infiltration of the liver and obesity interfere with adequate penetration. Shadowing from the rims and narrow intercostal spaces also make this approach challenging. The right adrenal gland may be obscured by gas and food in the second portion of the duodenum. It is important to differentiate the crew of the diaphragm as a tubular structure located medial to the right adrenal, as it can be mistaken for a normal gland. The right adrenal gland is usually displaced posteriorly when the retroperitoneal fat line is displaced by liver disease. Structures that converge in the area of the left adrenal may mimic this gland. The esophagogastric junction, stomach, gastric diverticula, splenic vessels, portosystemic collateral vessels, tail of the pancreas, prominent hepatic lobes, medial lobulations of the spleen, superior lobulations of the kidney, or adjacent tumors. A more posterior lateral approach, or the cavo-suprarenal line position, may be indicated for proper visualization of the left adrenal gland. Normal sonographic anatomy. Fetal adrenal glands are quite large, and 90% of the time at least one can be imaged after 26 to 27 weeks gestation. In adults, the adrenal glands are much smaller. The glands are generally located anterior, medial, and superior to the kidneys and vary in shape and configuration. Their size varies from 3 to 6 centimeters long, 2 to 4 centimeters wide, and 3 to 10 millimeters thick. The adult adrenals weigh 4 to 14 grams. Transabdominally, the cortex and medulla are usually sonographically indistinguishable, as the normal internal texture appears homogeneous and hypoechoic. The glands are usually surrounded by highly echogenic fat, and in some patients, only the echogenic fat can be identified in contrast to an anechoic adrenal gland. Higher resolution transducers, such as those used for endoscopic and intraoperative applications, are able to routinely detect the hyperechoic medullary echoes against the hypoechoic cortical echoes in the hyperechoic halo of fatty tissue. Right adrenal. The right adrenal gland is identified superior to the kidney and lateral to the right crew of the diaphragm. On transverse section, the gland is described as having a triangular trapezoid or inverted Y or V shape, with the tail extending from the anterior medial aspect of the right kidney. In a longitudinal plane, scanning the medial aspect of the gland, the anterior medial ridge appears as curvilinear or S-shaped structure and is visualized posterior to the IVC, slightly above or at the level of the portal vein. Moving laterally in longitudinal planes through the right adrenal gland, the anterior and posterior wings spread open and the gland takes on an inverted Y or V shape. The anterior lateral portion is medial and posterior to the right lobe of the liver and posterior to the duodenum. Care should be taken to differentiate the right adrenal gland from the more medial hypoechoic anechoic tubular right crew of the diaphragm. Left adrenal. Lateral to the left crew of the diaphragm and lateral or slightly posterolateral to the aorta, the left adrenal gland is visualized superior and medial to the kidney. This gland is described as having a triangular or semilunar appearance. Since the stomach lies posterior to the lesser mental sac, a potential space that is usually collapsed, the superior portion of the adrenal gland can appear directly behind the stomach. The inferior portion of the gland lies posterior to the pancreas. The splenic artery and vein can be identified passing between the left adrenal gland and the more anterior pancreas. On longitudinal sections posterior to the pancreas, the left adrenal has a sonographic configuration similar to that of the right gland.